Dr. Fonseca and Dr. Alexander and Lorenzo Brito. Thanks a lot for giving us the time to conduct the debriefing and to share with our French readers the experience that you have had in Brazil. It is very important for our readers to look what's being done elsewhere, to understand the lessons that you have learned as doctors. Maybe by way of introduction, you can each of you just say what is your experience and what you've seen in the Brazilian situation before we talk about your study.
Yes, thank you, Xavier. My name is Dr. Alexandre Wolkoff. I'm a medical doctor, head of emergency department at a group of hospitals in the northeast of Brazil. We are currently still in the pandemic, but when it started, we had a lot of issues that we had to learn. So we had a lot of patients coming to us around 150,000 to 250,000 a month, looking for us for different symptoms. And we had to fast develop a protocol that would include network, mainly in the north, where we had some experience with some medications that we tried to adapt to this early treatment, trying to reduce the viral load of the COVID virus that we didn't know at that time how it acted. So we initially wanted to treat these patients with an antiviral drug and also with another drug with anti-inflammatory issues that would diminish what we were seeing then. We began then treating them with the early symptoms, just as 3 days, 4 days. We decided that as we had some experience with hydroxychloroquine up north, we used to treat patients with malaria. So we thought it would be a good idea to adapt this kind of treatment with the early treatment of COVID. That's what we did, and we started to see our numbers slowly, and we decided that it was a nice approach at that time. And in some instances, without any assurance at that time, we had less incidence of hospitalizations. The time has passed for us like through 2 or 3 months after that, and in April or March or May, last days of April, beginning of May, we started to look back to our numbers, and we decided to separate 17,000 patients, RT-PCR positives, and to check what we did with them and what were the results. At that time, we still had this group of doctors. We gathered like almost every day to discuss new evidences and to change experiences with other researchers. For us, it was Dr. Fonseca that contacted Dr. Harvey at Yale Public Health School of Medicine. And then we started to change experience with them. And it was very nice to hear what he had to say, because nobody had our numbers in the country. And we didn't change many experiences because we were so concentrated on the operation and treating these ill patients. Now in Brazil, we have 5,800,000 cases now, with 165,000 deaths so far, with 2.8 mortality rate. And our our numbers are much smaller at the network. So we have at medium, the half of these numbers of mortality. And this is due to many treatments, including for the most severe cases, creating opportunity for treating these patients in the ICU beds and respiratory devices that could allow them to survive the worst scenario of the diseases. So everything we did was the intention of saving lives. And we had these rates that is half our mortality country rate overall. In this study specifically, we tried to target what happened to the patients that didn't need to get into the hospital because they had early symptoms and we were sure that they were COVID symptoms. We tested them and they were RT-PCR positives. So we wanted to look back on equal groups of patients, even being a retrospective study. We wanted to make sure that the cofactors were the same at the groups. So Dr. Risch proposed a model that he used to overlook this retrospective data. And we submitted to him our data, and he confirmed what we were suspecting, that early treatment with one antiviral drug and the other, which was prednisone at that time, and we still maintain it from the 5th day of symptoms, they reduced hospitalizations. This was very important to us, so we could treat the most severe cases in the hospital, and the other cases were treated with follow-up from our telemedicine team, which we used a lot during pandemic, and we're still using it. We used to follow them with telemedicine and referring them back to ERs when necessary.
Well, thanks a lot for this explanation. And Sylvia, so you reached out to Harvey Risch. Can you explain us why? I mean, do you have ties with Yale, or is this because of the super?
Okay. This data was collected throughout the epidemic. We're still having cases, but not as much. And this is from the Northeast states. And daily, they start to show that this is mortality, increase in mortality. And this is Brazil, and this is our HMO data. And we started to see that. We started to see that we had less death. And yes, let's change that. And this is very raw data that shows that in groups, this is all the 17,000 patients that we saw in our ERs from many different states, and they had they were COVID suspects, and we had, this is very, very raw, but we saw that in 10,000 patients that did not take chloroquine and the ER, we had 715 admissions. That is 6%, and we had 0.5% of deaths. We had 50-something deaths. And here we see 58 deaths. And in 7,000 consecutive ER patients, they were prescribed chloroquine. We still have hospital admissions, but it was just 2.5%. And we had deaths, we had 8 deaths, and this is 0.11. This is very raw data, but that really pushed us to look at this in a more structured way. And the way we reached out to Dr. Risch, I forgot to introduce myself, but I'm MD, I'm a pediatrician, and I also have a master's in public health from Yale and a fellowship in infectious disease at Yale. I read one of the Dr. Rich's papers, and I was very interested. He writes very nicely, and he, with epidemiologic data in that paper, and it was in the American Journal of Epidemiology, he showed with epidemiologic data that there was no reason for that concern with chloroquine. And I was so delighted to read something so rational in using epidemiologic data that I got his email and I wrote to him saying that it was very nice that he put that so elegantly. And we were also physicians here in Brazil, and we were facing COVID, and we were also believing that early treatment could be the answer. So, and we start exchanging emails, and I don't know, I think the very first call we did together, Alexandre and I, and with the three of us, they started to really look at more carefully at our data. So changing, so this is the, we decided to see consecutive patients from all those different states in Brazil. It's just in 1 month, we had almost 25,000 consecutive patients with suspicion of COVID in our ERs, the ERs that Dr. Wolkoff coordinated in all over Brazil. Those are the very different states that we get those patients. And then we decided to really look at patients who would be at risk to be admitted, patients over 40 years old who had positive RT-PCRs. So we knew for sure that they had COVID. And this is just a description of the characteristics of them. And then when we look, this is all retrospective, but from those 700 something patients, we admitted 114. And when we look at in a multivariate logistic regression model, what were the risk factors for those patients who got admitted? And what we had, so now is 700 something patients, RT-PCR positives. We reached out to them to make sure that they did get the drugs. And at that time, we were delivering to the patients because it was very hard to find out in normal drugstores the chloroquine. And then we in this logistic model, we were able to show that the older they were, the more age was a risk factor for admission. Every 10 years after 40 years, they had 1.75 times more likely they were more likely to be admitted. Gender was not a problem, but obesity, diabetes, heart disease were all risk factors for being admitted. And surprisingly enough, we were able to show that having prednisone after the 5th day of disease or hydroxychloroquine in the beginning of the first year consult, but better if they had both the hydroxychloroquine in the first visit in the ER and the prednisone after the 5th day of the onset of illness, they had this protection factor of 0.4. So we had 11 deaths, and it was not significant, the difference between the groups who took chloroquine and who didn't take chloroquine. But the raw data is from those 11 patients, just one didn't take chloroquine. We also had a variety of drugs that people prescribed. So our doctors had the freedom to choose what they felt comfortable prescribing because they were already having all those issues about chloroquine. So we had patients who didn't get anything. We had patients who got azithromycin. We had patients who got ivermectin. And the best model is chloroquine, hydroxychloroquine in the beginning, and the prednisone and the 5th day on of onset of symptoms, and then the best model was the two drugs. We believe in that. I think it's strong data. And we've been using it again in this model. And Dr. Wolkoff and I, we've been teaching and talking, reaching out to doctors daily. And we using this kind of internet models that we were able to have in those platforms. And we are successful, I think. We were able to prevent, according to our study, up to 50 to 60% of hospital admissions, which is very much like the work that we saw published by the Marseille group that also decreased the odds of hospital admission. We do believe that this is not a COVID-specific antiviral drug, but it is a drug that might help. It's cheap. We didn't see any heart effects. And we do believe this is, if you are to use chloroquine, this is the time to use it at the time when we are having viral shedding, viral replication. I think that's it. I talk a lot. That's it.
Thanks a lot, Sylvia. If I may ask a couple of questions, probably, and I don't know who will answer. On the RT-PCR, do you know what is the cycle threshold that you used in order to confirm the COVID symptoms?
That's a very good question.
Yes.
I'm not.
The last time we talked, Xavier, you asked me about that. I went to the lab to find out which ones we were using as a reference. What they told me is that they don't do quantitative study, but they can know which cycle it appeared in the cases. And the last information they gave me was that this in this material that we had at that time, April and May, the median was in the 16th to 18th cycle.
Okay, so it was really you're really sure that they were positives with those cycles.
Yes.
Are you aware of what cycle threshold they've used elsewhere, like in Europe, for example, or in that there is some question around the number in France, for example, they were using up to 40, 35 to 40. You aware of that, or?
No.
Okay.
No.
Well, that's definitely the reason why I'm asking, is because there's been a series of questions around that. The second question I had is in the presentation that Sylvia kindly gave, at one point you're talking about chloroquine, and in the exhibit you're showing hydroxychloroquine. Are you always talking about hydroxychloroquine and sometimes you're using the short name for it? Or
No, yes.
No, that's an excellent question.
Okay.
For 95 of the patients, we used hydroxychloroquine. For a very small amount of patients, right on the beginning of our treatment in March, probably, but not included in this study, we use chloroquine. So for the purpose of the study, we use on all of them hydroxychloroquine. But I wouldn't say that we treated all of our patients at the network of hospitals with hydroxychloroquine, as we had some distribution problems. So another important thing is that we wanted to make sure that our patients left our ERs when indicated with the medication. So we wanted not only to measure the intent of treatment, but we wanted to make sure that they really received what they needed. Because right on the beginning, also in March, we had a problem prescribing some drugs that the patients couldn't have access. So for these patients that we studied, we also wanted, we were sure that we were measuring the intent of treatment, but we're also sure that they received the medication and they took it home with them.
Okay, and another question I may have is, what about dosage? Because the dosage of hydroxychloroquine has been highly discussed amongst in various studies and amongst doctors. Did you investigate a different dosage, or did you have a recommended dosage that you used?
Yes, that's another very good question. That was a huge discussion we had right early in the beginning, and we based our recommendation on the early treatment of malaria that we had experienced. So we decided to go with 800 milligrams on the first day, and then 400 milligrams for the next 4 days.
And that's what we gave to the patients in the little kit. So we know that
Yes.
that's what was prescribed.
Yes. We are aware of studies that used to recommend higher dosages and higher lengths of treatments. But we wanted to make sure that, first of all, we decided not to associate azithromycin with hydroxychloroquine. The point is that both drugs are possible drugs that enlarge QT interval. So we wanted to only give hydroxychloroquine. We didn't add azithromycin for most patients, or most of all patients. And because at that time also, let's remember the medical literature was arguing about the JAMA article, the paper, and the New England Journal of Medicine paper, that they had a lot of papers saying that it was very dangerous to do that in high dosage, and even in small dosage as we used to recommend, it could be an incidence rate of complications, which we didn't observe. That's another conclusion of the paper that we published in Travel Medicine. We didn't have any major complications with this treatment with hydroxychloroquine only and prednisone associated, but not azithromycin. So that the dosage was one of our concerns. We decided to go with this smaller dosage due to our malaria experience at the network, and it worked very well. We didn't have any major complications from that.
The network is the Happy Vida network of 4,000 doctors, yeah, that you're talking about, yeah?
I'm sorry, what was that?
The network that you're talking about is the Happy Vida network, yeah?
Yes.
Yes, the 4,000 doctors. So all of you discussed this, and basically you're now sort of transferring the knowledge or sharing the knowledge with this group of doctors, and then you getting the feedback. And did you ensure any form of control that each of the doctors was following the same thing, the same protocol, or did you share this, or could there have been some different interpretation of the protocol? Because I could hear that one of the statements that you made was really about the freedom of prescription. So you trusted the doctors with their ability to detect the symptoms, to give a clinical table for the patient, and then to treat. I'm interested to understand how can you ensure of stability or homogeneity of treatment amongst 4,000 doctors?
That's a very interesting question. The independence of prescription among doctors is a very important issue for us. And we were always worried about it, and we wanted to give them absolute freedom to prescribe whatever they wanted to or felt like they wanted to prescribe, but we also wanted to share our experience and what we learned with our patients. We did that in many ways. We did that meeting with doctors like twice a day, even during the nights and weekends. We did more than 200 or 300 meetings, presenting our data and sharing with them our experience. We also had access to the amount of prescriptions we had among this network of doctors. So we could control stock for our patients. And what we found out is that about half of them didn't prescribe as we were showing them for many reasons. They didn't believe the data wasn't published in a peer-reviewed magazine. For many reasons, half of the doctors didn't prescribe them. And we kept on moving. We persisted, and still today, we meet with them, we present our paper, published now, peer-reviewed. We show them our data compared to the country, and we try to tell them our experience. Of course, many still don't follow, and that's all right for us, but we want to make sure that all of them got the information. You know, that's one thing we're absolutely sure. This was one main motivation we have for publishing the paper elsewhere. We wanted to make sure that they get information from medical literature, peer-reviewed, and they make sure that they were positive in prescribing what we saw as a good opportunity to reduce our hospitalizations.
And it's very interesting that you're accepting the diversity of choices amongst doctors. And did you see some doctors that changed their attitude or their prescription habit once you've published the data, or?
It was very interesting. We had a large amount of doctors that changed their point of view regarding many drugs. As soon as we talked to them and presented why we were thinking that way right from the beginning. I have been to all the regions in Brazil, so I've seen this change in every place I went. It was amazing. First of all, we showed them that prescription wouldn't do any harm to the patients. That was their main concern. And then we showed that the hospitalizations reduced when we did that on the previous hospitals that the COVID reached us. So we had some time from hospital to hospital. The disease didn't get to us at the same time. So we had some time to check the data from one hospital and go to the hospital that was growing the incidence of the disease and warn people, listen, if you do this and that. It didn't work not only for hydroxychloroquine, but it worked for many other things that we adapted, such as heparin, for example, that we didn't use at the beginning. And when the medical literature showed us the incidence of DVTs and coronary events associated, we began to treat patients that were hospitalized with this drug. And we reduced the numbers of this also. And we showed them and they really changed. I still remember when I went to Silvia's region with this, which is in the southeast of Brazil. And I have already passed with the north and northeast part of Brazil that the disease first came on the capitals, on the main cities, on the big cities, and then it migrated to the interior of the country, where Syria is. And when I remember, I went there in July, and the prescription incidence among the doctors in the city and in our hospital was very low as 14%. With everything, every meetings we had, and Sylvia was there talking to people. And when the disease reached our hospitals there, we could show them, listen, this is our data. I have been to the front. I have seen these patients. I have treated these patients. And then it changed dramatically. From July, middle of July, so far, November, it's still like 60 to 70% of doctors prescribing this protocol. I've seen this change a lot.
And we've talked a lot about the drugs. If I may ask, and about the doctors, it's very interesting that you managed to help them to make up their mind. Let's talk a little bit about the patients themselves. When you're seeing patients who are suspected COVID in Brazil, what state of mind are they in? Do you help them? Do you educate them over social distancing? Or do they come in fear, or are they worried about the situation, or do they come and see a doctor that knows what he's doing, that will help them cure?
Oh, I've seen them all. I've seen people with very scared of the diagnosis of the disease. I've seen people denying even catching the disease because of the possible stigma that they get from getting COVID, social stigma, I mean, from patients that had a lot of information about the drugs. And what we did was, first of all, to distribute papers among the doctors so they can share our knowledge on how to isolate socially on their homes and take care of their family and friends. We did that as a routine, and it was probably 80% of our work to
educate
tell people, yes, to educate. Probably 80 to 90% of our job was to do that, because there is a lot of confusion of information.
Yeah, a lot of confusion. Does that come, where does that come from? Does it come from media exposure, because in Brazil, you've had in general a lot of exposure to some serious disease like Zika or other, I would say, tropical disease, and the Minister of Health is very well trained for this. You would expect the citizens to be, I would say, very sensible and sensibilized to these issues. So do you think that there's been a lot of media exposure that could affect the way they think, or it's social network?
I think we have to differentiate the public system from the health maintenance organization systems. The public system had a lot of information that came from the Ministry of Health and the state departments of health. And they usually did a good job educating people, mainly in the primary care facilities and teams. In the private sector, generally there is not a lot of investments on the primary care. So people look for the ERs as a primary source of information, especially regarding that the other sources and points of contact of people for the private sector were closed. let's remember that we closed our secondary points of access to people, to specialists. We canceled surgeries, so we didn't expose people without COVID to COVID that they needed not urgent care. So I believe that the ERs were the first and in many cases the only access they had to the private sectors. I think education at that point was very important.
Okay, thanks a lot for this. And just one last question on the patients. We've talked a lot about the ER patients or the early treatment of patients. Have you had any exposure to ICU patients or very severe where they've been, and what protocol did you use? Did you use remdesivir or any other types of drugs?
No, it's an important question. First of all, the freedom of choice of the doctors led us to study different groups of patients in this study. So we had an ivermectin group. We had nothing, just symptomatic drugs group.
Placebo.
Placebo group. So the other thing is that when we got into the inpatients, we had a specific protocol to be prescribed for those who went into the wards and those that went into the ICUs. We had a specific and strict protocol of ventilation and avoiding ventilation in this group of patients, as well as a drug treatment protocol that we monitor very closely. Silvia is showing us our protocol for the moderate cases that went into the wards. That included not only oxygen and EKGs and drugs like antibiotics. We also included ivermectin because we usually deal with immunosuppression patients, and also the dexamethasone dosage we use had some concern regarding strongyloidiasis, which is sometimes endemic. So we wanted to still use ivermectin for those who went into the wards. For those patients that went into the ICU, we had the specific protocol for high flux nasal oxygen, which is showing us now. But we didn't use any remdesivir. We had one or two patients that used use convalescent plasma. We had two patients in all that, but that was all. The ICU protocol was very strict to monitoring and treating patients with that medications that we believed was good with that.
Well, thanks a lot for that. Have I missed any important things for Brazil or for trip or anything that you think is important in your study that you would like to share?
We are very thankful for the opportunity of sharing this with as many people as we can reach. Our experience led us to believe that the early treatment really makes a difference. We wanted to share this because it can be useful to other doctors. And we are very happy to do that as many times as you want. If you know anybody, any doctor, anywhere, anytime that wants to talk to us about this, let us know.
We heard of countries who even don't have, not only don't have ICUs, but they don't have ventilators. So we do, our main goal with this is not the fame of the glory, but it's really to share with the great part of the world who won't have monoclonal antibodies, won't have the thousands of doctors around, won't have anything. But in many of those countries are also very familiar with chloroquine, hydroxychloroquine. So that's why we look for to publish, to put in a good journal. And we did it, it's free access now, because we felt that this is the way to reach out to other doctors. So this is what we want. We don't want to fight with anybody. And one thing that Dr. Wolkoff says, perhaps 100% of the times we are training doctors, is this is what we know now. This is a new disease. Information comes and goes. We are trying to treat patients. That's what we are doing. And that's why in my beginning was my first statement. I think this is the greatest message. We want to treat patients. We want to do something. We want to, for them not to be admitted. And we are great speakers of, masking. And I gave, I don't know how many videos to all over Brazil, talking about the importance of masks, the importance of hand hygiene. And that's what we are doctors, and we want to patients not to get it, but if they get it, to be treated as early as possible. I think this, well, I'm sorry to interrupt you.
No, thank you very much for your time, Sylvia, Alexander. It's really very interesting for us as French citizens and for our French readers, that we can export this knowledge or import this knowledge and share. I personally believe, as the director of publication of France-Soir, that the success of what's being done elsewhere, be it in Brazil or in Morocco and Senegal, is important, and this is the way that you usually share science. It should not be politicized. It was a lot politicized in France, and I really appreciate spend your time explaining what happens in Brazil. I personally spend a lot of my time in Brazil, and I really like this country. So that's why I reached out in that we also looked at the statistics of Brazil. It was really difficult to find the statistics from Europe to understand what was happening in Brazil, and sometimes going to the doctors makes the most sense because you're on the ground, you're seeing the people. And thanks a lot for all that you did and for taking the time to speak to us. So I just wish you a nice evening, and let's hope that you continue to do your very good work.
Thank you very much, Xavier. Thank you.